Hello, everybody. Good evening, good morning, and also from all from the world. Welcome to our conjoined web from the iPods and ePods. I will make an introduction first. So this is a beautiful background from Egypt. And so this is a conjoined webinar on the topics of adult strabismus. Today we have a few very renowned speakers to cover the topics on various topics on the adult strabismus. So this is a conjoined webinar by the IPOS, International Pediatric Ophthalmology and Strabismus Council, which is a council of national and supranational organization. We have nearly around 90 countries and supranational organization and interest group to preserve the health of the children's eye care and also the ocular alignment of the adult and children's strabismus. And also, we are very privileged to work with the EPOS, the Egyptian Association of Pediatric Ophthalmology and Strabismus. And for this conjoined webinar, we welcome you all here, and we hope you all have a very fruitful learning and discussion for today. So myself is one of the moderators today. I'm Jason Yam, Associate Professor in the Chinese University of Hong Kong, and I'm also the head of the Pediatric Ophthalmology and Strabismus Service in the Hong Kong Eye Hospital and also the Hong Kong Children's Hospital. I'm also serving as a chair of the Training Education Committee of the IPOS. And also the Secretary General, and our speaker today, one of them, the first one is Jan Tier Devara. I know him very well, the head of the Japanese service at the Usaki Clinic, Rotterdam, Netherlands, the consultant ophthalmic surgeon at the Rotterdam Zoo Bishop, and also the chair of the medical staff at the Rotterdam Eye Hospital from 2009 to 2013. He is also our vice president of IPOS and also the former president of the Dutch Ophthalmology Society, NOG, in 2006 and 2009. He is also the outgoing president of the European Society of the Ophthalmology. Our next star speaker is Dr. Hala El-Halali. She is the Emeritus Professor of Ophthalmology in the Cairo University in Egypt. She is the Pediatric Ophthalmology and Strabismus Consultant and the former Director of Pediatric Ophthalmology and Strabismus, the Children's Hospital in the Cairo University. And I would like to also introduce my partner, our second moderator, Dr. Ama Elkam Shushi. He is the assistant professor of ophthalmology of the Alexandria University of Egypt. So may I now invite Ama to introduce our next speaker.
Thank you, Dr. Yam. It's my pleasure to be co-moderating this webinar with you tonight, and we would like to thank you for this introduction. We all thank Dr. Yam. It's very late at night where he is. It's almost 2 a.m. and we're keeping him up late. Next, it's my pleasure to introduce Dr. Mohammed Jafar. He's the Weinstein Professor and Chief Emeritus of Ophthalmology in Children's National Hospital, Professor of Ophthalmology and Pediatrics in the George Washington University, and the Advisory Board Chair of the IPOSC. Everyone knows Dr. Jafar and his interesting presentations. We're very happy to have him with us tonight. And last but not least is Dr. Hatem Saeed, a Professor of Ophthalmology in Cairo University. He's a pediatric ophthalmology and strabismus consultant. Has great experience in strabismus and pediatric ophthalmology, and we're sure going to hear a very interesting presentation tonight. Without further ado, we'd like to start our program tonight. And our first speaker is Dr. DeFaber, and he's going to speak to us today. His talk is titled Progressive Myopia and Esotropia. Dr. DeFaber, please.
Sorry, yes, it's There we go. Good morning, good evening, good afternoon, and good night for everybody. I will talk about progressive esotropia in high myopia, and especially about the heavy eye phenomenon. But my first question to the audience is, how heavy is the heavy eye? Do you know how heavy a normal eye is? An eye with 24 millimeter axial lengths. And I will give you 4 options, and keep them in mind, because at the end of the presentation, I will give you the right answer. So it's 60 grams, 30 grams, 15 grams, or 7.5 grams. What I would like to talk about is what Professor Yokoyama already taught us in 2000 in the ESA meeting in Barcelona, is the mechanism of development of progressive esotropia with high myopia. And 1 year later in Florence, at the ESA meeting, he proposed a treatment for it, and this has gained a lot of popularity, and I will talk about it a little bit more. And this is a animation which he presented in 2000, and which I'm very happy that I can share this with you. This is a 30 millimeter axial length globe, and what you see, it's not a round globe, but it's like an egg. Here you see that simulation animation once more, and you see that this is a right eye, that the superior rectus and lateral rectus are pushed away by the herniation of the bulbus outside the muscle cone. And this is the treatment he proposed in 2001, the union of half of the lateral rectus and the superior rectus to close the gap. And in honor of his achievement, he got the Belchowski lecture in Kyoto at the ESA meeting in 2014, because he was a real pioneer in this field, and we owe him so much. And what happens is that he showed that the angle between the superior rectus and lateral rectus really changed in strabismus fixus. So you have high myopia with no strabismus, and this will go to intermediate esotropia, and sometimes, if it's really bad, it goes into strabismus fixus, just to show how progressive this is. So you have here high myopia, where the angle between the dislocation of the muscles is 115 without strabismus, and when it goes to about 181 in this case, you have intermediate strabismus, which means that you have esotropia, but you can still abduct. And if it gets, in the last case, to 247 degrees, you have a convergent strabismus fixus. That's a strabismus and esotropia, which cannot get out of the adduction. And I show you several cases of that. And here you see, once again, the illustration how his technique is. And this is already described in the transactions of the European Strabismus Association in 2001. And once again, the severity of the globe dislocation will really dictates how whether this is no strabismus, intermediate strabismus, or strabismus fixus. And again, the critical points of the surgical technique that you need to use 5-0 unabsorbable sutures, polyester sutures. It has to go twice to half of the muscle belly in both muscles, and then tie them together without leaving a gap between the two muscles, because you are closing the herniation pathway of the bulbus. And here you see an improvement of this globe dislocation. This is a patient of Dr. Yokoyama who had preoperative 206 degrees dislocation, and postoperative he could close the gap to less than 110 degrees, and getting the globe back into the muscle cone. And this is a patient of mine to show that heavy eye is a progressive strabismus phenomenon. You see on your left the same patient, 20 years old. He has -24, -20 contact lenses, and you see about 25 years later, he has strabismus, convergent strabismus, but not yet fixed. Now I come to Dutch stories. We have Hans Brinker, and Hans Brinker is famous because he, with one right index finger, he could close the gap of the dike, because half of our country is below sea level, and dikes are very important. Now I show you that right index fingers can also be helpful in the diagnosis of the heavy eye phenomenon. And here you see a patient with intermediate esotropia, so not strabismus fixus yet, 3 months before I do the surgery. She had a waiting time for about 3 months. And here you see her adductions. She's looking now to the left, and you see, look, the left eye still gets over the midline. And now, of course, you could say, do we need to do MRI imaging? I give you 4 options. You always need an MRI, or a CT scan is easier and cheaper. Do an MRI only when you're in doubt of the diagnosis, or is the axial length actually the deciding factor? So a 25 millimeter bulbus will not have a heavy eye phenomenon, but a 30 millimeter will. But my statement here is, do an MRI only when you're in doubt whether the clinical picture is according to the heavy eye phenomenon, and then that you can go ahead with the Yokoyama surgical technique. So is the clinical picture enough to guide you safe to appropriate surgery? And in my country, an MRI will double the price of strabismus surgery, which means surgery is as expensive as an MRI. So I will do my Dutch MRI, and MRI in the next case is my right index finger, not magnetic resonance imaging. And here you see the same patient 3 months later, and it's just minutes before I do the surgery. And look what happens. I was really shocked by it, because the normal esotropia became strabismus fixus, but with a little help of my right index finger, I could push it back inside the muscle cone. There we go. She goes to looking to the left, and then I push a little bit, and there you see that the muscle goes, the left eye goes back into the muscle cone. So I push back the herniation. There we go again. And I use my MRI, my right index finger. So this is a very rare case in which you see that the intermediate esotropia and heavy eye phenomenon is almost strabismus fixus. And with a little help of my right index finger, I could push her back into a normal situation. So my right index finger saved 1,200 euro, and so they call me now Dr. Goldfinger in our department, because I'm how do you call it, thrifty, but that's typical Dutch. And here you see the same patient 8 weeks after Yokoyama sutures and medial rectus recessions because they were tight, so I had to do them as well. And this is the result. After bilateral Yokoyama sutures and medial rectus recession, and I thought this was actually an excellent result. Thanks to Dr. Yokoyama, who taught us to close the gap of the herniation. And during surgery, this is what you see. This is a left eye, and you see that the lateral rectus muscle is pointing downward. So it doesn't go to the canthus here. It goes in a trajectory too low, which means that there is a herniation here, because this is the same patient, and you see the superior rectus, which has a nasal displacement, and so actually in the operating theater you can actually see what is going on, and you can use the Yokoyama technique to close that gap. Oh, so to come back to how heavy is a normal eye, and normally this is overestimated, and the right answer is that a 24 millimeter axial length eye is only 7.5 grams. I thank you very much for your attention.
Thank you very much, Dr. De Pava's very excellent presentation to share the case on the heavy eye syndrome. So may I now invite our panelists to comment or to ask any questions? Any question from our panelists?
While yes, more serious questions, does this work with the left index fingers, Jan?
I have a case with the left right index finger because I had a right eye doing this, and of course it's the same technique, but then it's not an MLI, and that's it saves the same amount of money, but it's not an MRI.
Okay, how about Dr. Halani?
Yes, I just wanted to ask you if any of the sutures that you took in any of the patients tore through, or the effect was undone after surgery, and if you have experience with that.
During surgery, I've never experienced that, because you have to be delicate not to take the whole muscle, but only part of the muscle. The suture does not need to be pulled through the sclera, so you don't touch the sclera, and you have to go at least at the equator. So that's about 12 to 15 millimeters back from the insertion, in order to get a good closure of this herniation of this oval globe.
I'm talking after the surgery, like if you have an unwinding of the effect post-operatively.
I've seen some under and over corrections. The over corrections, I had to undo the suture and undo the scarring. And under corrections, I went back to the suture, and it was still in place, but I had to do a little bit more of the medial rectus recession in order to get a good result.
And so how much medial rectus recession do you normally do with that? And how do you titrate that? I'm feeling how tight is the medial rectus muscle, and especially if it is in a long-standing strabismus fixus, it can be very tight. Mm-hmm. And the tighter the muscle, the less recession you have to do, just simply by releasing the muscle and do 5, 6, or 7 millimeters together with the Yokoyama suture will fix the case. The point is that first the eye gets herniated, and then you will get slowly a progressive fibrosis or tightening of the medial rectus muscle. And so you actually have to do both in these strabismus fixus cases. So a recession of the medial rectus plus the Yokoyama suture. And in some cases, if the medial rectus is not tight, in the intermediate cases, you don't have to do a medial rectus recession. Only a Yokoyama suture will fix this.
Jan, Joe Diemer and his associates have talked about the sagging eye muscle syndrome.
Yes.
And I don't know how you do it, but when I have something like this, I usually resect, with esotropia, I would resect the lateral
rectus
and take a posterior fixation suture to the sclera.
Yep.
Because muscle is a little bit downward. Do you agree with that? Is this what you do?
Yes, I agree on that, but that's a different situation. Of course, the band between the superior rectus and lateral rectus in the sagging eye syndrome is floppy or broken. So it has some how do you call it? You can compare it to a certain point with the heavy eye syndrome, but it's not really herniating outside the muscle cone. So it's a very subtle way of tightening the lateral rectus, and then take one fixation, myopexia at about 8 to 9 millimeters from the original insertion to fix the sagging of the lateral rectus muscle.
Also, we have some question from the audience. Can Ahmed help to?
Dr. Faber, seems your presentation sparked a lot of discussion amongst the audience here. First, there's a question that's been repeated in different ways about how do you do like the dosing of this surgery and the location of the Yokoyama suture? Do you do it like one size fits all, or what's the place of the Yokoyama suture? Does that affect the amount of correction that you expect?
No, I think the main thing is that large eye has to go back into the muscle cone. How you do it, I think the way I do it, which I learned from Dr. Yokoyama, is a way to do it. Some people use silicone band material, but I think it's a very good idea to only take half the muscles and go from there. Once the bulbus is back into the muscle cone, then you can of course titrate remaining esotropia with recession of the medial rectus muscle. But the main thing is put the eye back into the muscle cone and then go from there.
Do you pass the suture through the sclera?
No, it's not necessary.
You don't think it's necessary? Okay.
No.
And do you think it's necessary to use always non-absorbable? Or if you use absorbable sutures, it'll still give the same result?
In non-absorbable sutures, you really know that this suture will stay. In absorbable sutures, you hope that you get an adhesion between the superior and lateral rectus muscle. I haven't tried it, but it could very well be that people are successful in using that technique. I haven't tried it.
And the material you used in this case is what? Did you use Merceline, scleral band, silicone?
No. I leave that to our retinal surgeons, and they can mess up the muscles with that material.
Okay. I have a lot of questions, but we have a question here that says, we often get normal MRI results regarding the extraocular muscle path, yet clinically it's a picture of heavy eye syndrome. And you see displacement intraoperative. How would you deal in such a situation if you have the MRI not showing it, but the picture is clinically suggestive? Would you do Yokoyama, or you would treat it as a classic esotropia?
Well, if the muscle, if the eye still goes past the midline and you don't have an hypotropia, do it as a classical esotropia. And remember that I only do in a very few patients, I do an MRI. So when I start for a clinical picture with heavy eye, I don't have an MRI. I don't even have a normal MRI. I only have the clinical picture. And I go from there. And if I see during surgery that the superior rectus goes more nasally and the lateral rectus goes more downward, then you can actually draw a line and see this is more than 150 degrees or almost 200 degrees. And then, you know, this is the clinical picture, put a suture in and go from there.
So we use the clinical assessment to make our decisions. That's better. That's what you recommend. That's
what the situation in my clinic is. I can imagine that less experienced colleagues would really like to image, but imaging is it's expensive, and Dutch people are thrifty, so I do without.
Okay, I'm sorry, I'm going over the questions quickly, but we have a lot of questions from the audience and I'm trying to cover as much as possible. The last question would be, it came up in different ways, like how would you differentiate the heavy eye syndrome from the sagging eye syndrome? Whether the index finger test would help to do that, or in general, how would you differentiate between both?
No, the index finger will only help in heavy eye syndrome when they're just in between the intermediate and the strabismus fixus. And you saw the patient, and I have several of them, that they were still intermediate esotropia, not strabismus fixus, and then over a couple of months they can become strabismus fixus, but with a little help of this pushback maneuver, you can see, okay, this is not strabismus fixus yet, but this patient needs a Yokoyama suture. The sagging eye will probably not, my right index finger will probably not differentiate that from an intermediate esotropia. And it's sagging eyes, it's not shagging eyes.
Okay. Thank you, Dr. De Faber. We still have a lot of questions, but for the sake of time, we're going to have to move on. I invite the audience to please send your questions and answers on the Q&A section, and we'll try to cover as much of them as possible. We now, for the sake of time, we're going to have to move to our next speaker. Dr. Hala Al-Hilali is going to present dysthyroid myopathy. Dr. Hala, please go ahead.
Dr. De Faber, have you unshared the screen? Your screen? Thank you.
Dr. Hala, we can see your screen now.
Yes, I'm just trying to get my presentation going. So thank you very much. I'm talking about thyroid eye disease. Thyroid eye disease is an autoimmune disorder. It's caused by the production of autoantibodies to thyroid stimulating hormone receptors. And because the extraocular muscles and the orbital fat share autoantigens with these receptors, lymphocytic infiltration and edema of the extraocular muscles and orbital fat can occur as a result of an inflammatory reaction within the orbit. And the end result is fibrotic changes in the orbit and extraocular muscle tightness. So the surgical management of thyroid eye disease is always challenging. And strabismus surgery should be preceded by orbital decompression if that is needed, if that procedure is needed, because it can alter the already pre-existing deviation or even result in a new deviation. Strabismus surgery is deferred 6 months after orbital decompression to give a chance for stable measurements and stabilization of the measurements. And after strabismus surgery, lid surgery can be done. So the basic surgical strategy is we aim at eliminating diplopia in the primary position and down gaze, which are the two most important positions for the patient. And we aim also at providing the patient with the largest single binocular field we aim at recessing tight muscles and tend to avoid resections as much as possible. It's important to obtain orbital CT scans or MRIs because they tell you the extent of involvement of the extraocular muscles. You can see here involvement of the superior, medial, and inferior rectus in both eyes in this coronal CT scan. Orbital MRI, the sagittal section, will also show you the characteristic fusiform enlargement of the superior and inferior rectus muscles, sparing the tendons. Actually, my management of the thyroid eye disease has evolved over time, mainly from mistakes I made and lessons I learned. And I would like to share with you how that thinking and management evolved. So I will start with one of my very early cases. It's a 43-year-old male, heavy smoker in whom orbital decompression was not necessary. These were his measurements: 35 prism diopters of esotropia, 14 prism diopters of right hypotropia. Hypotropia increased in up gaze to 25 prism diopters, decreased in down gaze. This is the composite of his movements and the reductions of his versions. In the primary position, there was 35 prism diopters of esotropia, 14 prism diopters of hypotropia. And you can see the right eye with marked limitation of elevation. There's also marked limitation of abduction bilaterally, -3 limitation. Based on the measurements I took and also on the forced duction testing that I performed at the beginning of surgery, the surgery was as follows: a right medial rectus recession of 5.75 millimeters, left medial rectus recession of 5, and I resected the right inferior rectus, suture 4.5 millimeters from the insertion, and I put them all on fixed sutures. They were all fixed. This is the post-operative alignment of the patient. The patient was ortho in primary position with improvement in elevation and in abduction bilaterally. But unfortunately, he developed 4 to 6 prism diopters of right hypertropia in down gaze. The patient was actually extremely happy, and he was able to read with a small prism incorporated in his glasses, but I was extremely unhappy. And I learned these lessons early on to target orthotropia in down gaze and leave the patient with a small hypotropia in primary position, because the patient can compensate for with a slight chin elevation, whereas the patient cannot compensate for a hypertropia in down gaze. I've also learned that the extraocular muscles in thyroid eye disease behave are in a variable way, and there's a variable dose response per millimeter of recession, and that fixed sutures do not provide optimal results. So this is again one of a second early case. It's a 61-year-old male. Orbital decompression was performed 8 months before he was referred to me. And he came with the unusual complaint of torsion of diplopia. Usually this complaint of torsion is masked by the vertical and the horizontal elements of diplopia. And so the fundus exam showed an excyclotorsion of about 20 degrees, which is expected with marked inferior rectus contracture. And this is the patient's subjective excyclotorsion with a double Maddox rod. He measured 18 degrees of excyclotorsion. And these were his measurements: 40 prism diopters of esotropia with a right 25 prism diopters of hypotropia, -4 limitation of elevation of the right eye, and -3 limitation of abduction bilaterally. And in this case, I decided to use intraoperative relaxed muscle positioning. And by doing that, I recessed the medial rectus 6.75 millimeters in the right eye, the left 6 millimeters, and the inferior rectus was recessed 8 millimeters. The inferior rectus muscle was not fixed to the globe, except after I made sure by fundus examination intraoperatively that the excyclotorsion was corrected. And it was the patient post-operative alignment. 6 weeks later, he drifted gradually into a post-op intermittent exotropia, 16 prism diopters, and a small right hypertropia of 4 prism diopters. The patient was able to fuse the exotropia most of the day, but complained of diplopia when he was tired at the end of the day. And so there were lessons here that I learned the hard way, that relaxed position without post-operative adjustment can lead to overcorrection, and that the best way to deal with these patients was actually using adjustable sutures and leaving the patient slightly undercorrected. So with medial rectus recessions, now I leave the patient with a residual esotropia of 2 to 4 prism diopters, and with inferior rectus recessions, I leave them with 6 to 8 prism diopters of hypotropia, because that yields better long-term effects. This third patient, it was a 42-year-old female with unilateral thyroid eye disease. Orbital decompression was performed 6 months prior to her, before she came to me. She had a stable angle of deviation with left esotropia, 30 prism diopters, and a marked hypotropia of 45 prism diopters. So this is her primary position deviation. Actually, the eye was stuck in a down and in position, and it was impossible even to get her to move that eye into primary position. The right eye was completely normal. There was -5 limitation of elevation, -3 limitation of abduction in that eye. And the marked enlargement of the inferior rectus was confirmed by her CT scan, and by that time, I really think I got the hang of it. So in that patient, I secured the inferior rectus and disinserted it, and then repeated force duction test for the medial rectus, superior rectus, and the obliques. And when I did that, I found that the medial rectus tightness was much less than what I encountered prior to the inferior rectus disinsertion. So actually, the tight inferior rectus muscle can give you a false impression of tightness of other muscles, and that is why you should repeat force duction after disinserting each muscle. The superior rectus muscle was not tight, so a large inferior rectus was done on that eye. The medial rectus and the inferior rectus were placed on adjustable sutures. I didn't need to readjust the medial rectus, but I had to put the inferior rectus back another 2 millimeters. And at the end of adjustment, I left the patient with 4 prism diopters of esotropia and 8 prism diopters of hypotropia. It was her early post-op follow-up. She had a small hypotropia of 6 prism diopters. She was able to fuse that or compensate for that with a small chin elevation. It was her post-op follow-up a little bit later on. Again, the hypotropia was down to 4 millimeter prism diopters in the left eye. And this is what she looked like. You can see the top picture is the patient preoperatively prior to surgery. The middle picture is after the strabismus surgery, and the lower picture is after the lower lid lengthening procedure. And she was really happy. The last case is a case of a 48-year-old female with history of strabismus surgery for thyroid eye disease a year prior to her presentation. She complained that the left eye drifted upwards after surgery. There were no surgical notes or records available. And this was before her measurements. She had left 30 prism diopters of hypertropia in the primary position. There was marked limitation of left depression, and there was a suture granuloma that I could see at the nasal border of the inferior rectus muscle, and there was significant fundus intorsion. So it was a post-operative overcorrection, and there are many mechanisms that can account for that. One of them is a shortened arc of contact with impaired adhesion of the inferior rectus to the globe, or adhesion of the recessed inferior rectus to Lockwood ligament, weakening depression, stretched scar, slit inferior rectus muscle, or increased tone of the ipsilateral superior rectus. Preoperative MRI was done and showed a marked enlargement of the superior rectus, and intraoperatively, I found that the inferior rectus had been recessed 5 millimeters, no slippage, no stretch scar, it was in place, but the superior rectus was extremely tight. And in that case, I recessed the superior rectus 8 millimeters on adjustable suture, and this is the post-op appearance of the patient. Now she could depress her eye pretty well, and she only had 2 prism diopters of left hypertropia in down gaze. So how can that be avoided? You don't want to miss in the preoperative evaluation that the superior rectus or the inferior oblique could be tight, but that tightness can be masked by a tighter inferior rectus muscle. So a good clue to that is take a look at the fundus, because with the tight inferior, if only the inferior rectus is the tight muscle, you will find excyclotorsion. If you don't have excyclotorsion, then you can suspect the superior rectus or the superior oblique to be tight. You can also take a look at the patient's MRI, and they will confirm whether these muscles are enlarged. During the surgery, what you don't want to miss is to do a force duction test for all muscles. Repeat the force duction after disinserting each muscle, and if the superior rectus is tight, you can reduce the amount of inferior rectus recession or add a superior rectus recession to your surgery. And finally, to optimize surgical results, wait before the strabismus surgery for stable alignment. The patient is usually nagging and really wants to have the surgery with the bothersome diplopia, but we should wait until stable alignment is obtained. Goals and expectations have to be discussed. The patient has to understand that he will not be completely diplopia free, but that we're aiming at reducing the diplopia in the side gaze, but giving him a primary position and a down gaze that is diplopia free. I usually try to get away by doing a unilateral inferior rectus recession in asymmetric inferior rectus involvement, because I find that bilateral inferior rectus recessions will lead to more complications, such as an A pattern in down gaze with intorsion. Now that can be avoided, the A pattern can be avoided by a nasal transposition of the inferior rectus muscle, but that would increase actually the amount of intorsion. So if at all possible, and if the patient doesn't have a significant limitation of elevation bilaterally, a unilateral inferior rectus recession is probably better. Fine-tuning is obtained using adjustable sutures. You can add a conjunctival recession and leave the patient slightly undercorrected. I've used absorbable and non-absorbable sutures, and I haven't found any difference. It's important to carefully dissect the Tenon's capsule on the undersurface of muscles in order to avoid non-adherence to the globe. Thank you.
Thank you very much, Dr. Halali, for the very excellent and great talk. May I ask the panel, do you use adjustable or you use a fixed suture for the thyroid eye disease, for the strabismus? Can you have an indication whether you use adjustable or not?
Fixed.
I'm never using adjustable sutures. I adjust after 3 or 4 months if it's not right with another surgery.
Thank you. How about Dr. Jaffa?
Fixed sutures. I don't use adjustable sutures. I do not use adjustable.
Mm-hmm. How about Dr. Seed?
Sometimes, yes, we use adjustable suture in thyroid eye disease, but I'm not a great fond of adjustable sutures. I mainly use fixed suture too.
Okay. So any questions? I sometimes also use adjustable and sometimes use fixed suture. And so any questions, comment from our panel on the thyroid eye strabismus?
Yes, if I may, Jason, Hala, this was a very useful lecture, and many pitfalls you described I made myself, and I learned it the hard way. And especially the late overcorrections if you do an inferior rectus recession. And I think a very good point of view is that if you take one muscle off, redo your force duction test, because that is a very useful help in order to determine whether you have to do another medial rectus or oblique muscle. And I thank you for that. You pointed that out very, very well. Thank you.
Hala, again, thank you very much for this excellent presentation. You hit on all the proper things, including the overcorrection. I would say that we are our most stringent critics of ourselves. So many of the undercorrections or overcorrections that you got, my patients make, and not me. The question that I have to you and to the panel is, are you impressed with any significant rate of slippage of the inferior rectus, specifically any significant rate of stretch scar? I have not.
Actually, in all the patients that I've had to go and reoperate on for overcorrections, I haven't found that I had a slip muscle. And I've always found that the most common reason for this overcorrection is that there is an increased tone in the antagonist, because this is an ongoing, it's a disease that involves most of the muscles, and there's always like a balance between these muscles, and when you tip the balance or tip the scale in one direction, then the other muscle will start to become tighter. That's my impression.
Yeah, this is why undercorrecting is the way to go.
Yes, yes.
Thank you. So in the interest of time, may I invite Dr. Shaoshi to moderate the question on the floor?
We have a lot of questions. We'll try to cover as much as we can. Dr. Hala, we have a question first about what adjustable suture material do you prefer to use for the inferior rectus?
The Ethibond.
Yeah.
The Ethibond.
Okay, you don't use absorbable sutures in that one?
Actually, no. I've used them both, and I haven't found a difference between using absorbable and non-absorbable sutures, and I find that the muscle does stick to the globe. The only trick is really that you have to remove the tenon and the connective tissue on the undersurface of the muscle to give that a chance to stick, but that's all.
Okay, another question for Dr. Hala, or anyone has the experience. Did anyone have the experience with Tepeza, the teprotutumab, which is described for as an effective reducing the acute muscle edema and may reduce the need for strabismus surgery? I have not had the experience with this medicine. Did anyone of the panelists use it before?
I haven't.
No, I haven't. I haven't either.
Okay, so no one seemed to have experience with it. What about the intorsion? Did you consider doing superior oblique surgery, measuring the torsion before the surgery, or intraoperative torsion, and doing a superior oblique muscle surgery for the torsion, Dr. Hala?
So actually, I haven't done superior oblique surgery on table for the torsion, but I have done superior oblique surgery when that develops later on. Now, usually you may not get the intorsion on table, but the intorsion develops later on, because when the patient starts to look down and doesn't have the inferior rectus working for him, he's recruiting the superior oblique, and that's something that you will find not on table, but in the post-operative period. And when that happens, yes, what I would do is a superior oblique weakening procedure for that. And Dr. DeFabro, do you have something that you would like to add?
No, actually, that is a good point. Do straightforward the inferior rectus, and if need be, the medial rectus, and see where your measurements will bring you. Don't over correct, under correct, and if there is any intorsions, you can deal that with a second surgery.
Yes.
Okay, then about the timing of the surgery, we have a question raised here about how do you confirm the stability? MRI with contrast or just clinical observation for 6 months? I mean, these cases are always changeable. When do you decide this is the right time to operate?
Actually, I wait 6 months, and I bring the patient in for several measurements, and I make sure that I'm getting the same measurements every time. And usually these patients are very impatient because they want to have the surgery and they're bothered by it, but you just have to wait until you reach a stage where the measurements are really stable.
Yeah, I always ask myself if I'm really rushing to do these cases, because I do them after 6 months of stability. And that brings us to the next question, which is, how much of a recurrence rate do you have in these cases? Do you think it's a rough estimate how much recurrence you have in thyroid eye disease?
You mean by recurrence over correction, or you mean the rate of reoperations?
Yeah, I would say unhappy patients where you have to go again.
I would say maybe 15% of my patients I would have to reoperate on again. Now, a lot of them can be managed with other things besides surgery. So like the patient that can be fitted with prisms and for diplopia and down gaze. So you don't really have to rush to surgery again. But I think that that's about it, about 15%.
Which is a very good result.
Please go ahead.
Yeah, it's a good result. And here, Dr. De Faber, I'm always surprised how well these patients do, especially if they have had decompression surgery of the orbits. Because then after that, after the orbital decompression, they come to our strabismus department, and knowing everything about pulleys and how muscles go, and then you destroy about 3/4 of the orbit, and then I'm still surprised how nice anatomy still works, and the majority of the patients do very well. The patients you remember is that you have to do 5 times redo surgery, especially in patients who cannot stop smoking.
Mm-hmm.
It's amazing the amount of questions that we have about thyroid eye disease. I mean, we have a lot of questions here. I wish we have a whole webinar about thyroid eye disease once to address all the questions. But for the sake of time, we're going to have to move on. And now Dr. Mohammed Jafar will present the superior oblique palsy. And apologies to all the attendees who sent the questions that we've not had the time to address. Hopefully we'll be able to do that later. Dr. Jafar.
Thank you very much. Thank you, Amr. Thank you, Jason. Many thanks to the leadership of EAPOS and the IPOSP for organizing this webinar. It is always hard to follow Hala and Jan in the presentation, but I'm going to present a superior oblique palsy case, which is thankfully a much easier entity to deal with, but it does occur, and this is my take. I'm going to present a 71-year-old gentleman with history of a traumatic brain injury occurring. He presented to me 3 years afterwards. He was complaining of difficulty reading and walking down the stairs. He has no complaint in primary position, and his family has noted a right head tilt after his trauma. His eye examination was essentially fine, good vision in both eyes, minimal refractive error, and pupils were good, mild cataract, nothing really ordinary. His fundus was also normal. He had a normal optic nerve, which is, of course, very important to always look at the fundus examination in any patient who's presenting with an acquired strabismus. And something we're going to cover later on, he had a mild extracorrosion of the left eye. His measurements were essentially the same for both distance and near. In primary position, he had 5 prism diopters of intermittent exotropia with 2 prism diopters of intermittent left hypertropia at distance. At near, that increased a little bit to 12 XT and 3 left hyper, possibly because we were measuring him a little bit down gaze or downer gaze. His Bilshevsky head tilt test showed an increase in the left hypertropia with the left head tilt. So this is our gentleman with a right head tilt of around 5 to 10 prism diopters. His rotations showed a -1 under action of the left superior oblique and a simulated +2 over action of the contralateral right rectus muscle. Again, the head tilt. He had excellent stereopsis in the primary position of 40 seconds of arc. His double Maddox rod showed no torsion in primary position. However, in down gaze, he had 5 degrees of left X cyclotorsion, and fundus examination objectively showed 1 + X cyclotorsion on the left. Now I took off the intermittent exotropia that was well controlled, and I don't think it was part of the symptoms, and left the hypertropia measurements. As you can see in here, a small left hypertropia in primary position, essentially nothing gaze, but the left hypertropia increases in his right gaze, and definitely in down gaze. Straight down, he had 16 prism diopters of left hypertropia and 25 prism diopters of left hypertropia in right and down gaze. The three-step test of Parkes was straightforward. He had a left hypertropia in primary position. His hypertropia increases in right gaze. He had a positive Bilshevsky head tilt test, and these all, pointed to the left superior oblique palsy. So the diagnosis was not in question. The issue was, how are we going to help this patient without hurting him in other positions of gaze? So in summary, he is an otherwise healthy 71-year-old gentleman, no diabetes, no hypertension, no cancers of any kind, who had a traumatic brain injury resulting in a fourth cranial nerve palsy on the left side. And again, his complaints were difficulty in down gaze. And by measurement, his largest deviation, again, was in right and down gaze. This is a typical presentation of what NAP has classified as class 5 or class 4.5 or something like this, class 5, where most of the deviation is in down gaze. And as per Jampolsky and Von Norden and others that subscribe to that, it wasn't an overaction of the contralateral superior oblique that was causing this image, but it's usually, in the greatest majority of time, contracted left superior rectus muscle. In these patients, the hypertropia is in down gaze, it's maximal on the ipsilateral side, but our patient had an overaction in the contralateral side. Most of his deviation was there. So in these patients, I do, as all of you, depend on the forced action test. I usually reserve this to under general anesthesia because I'm really not going to gain much in doing it in the office, except the patient hating me. So under general anesthesia, I do a forced action test to check and see the ipsilateral superior rectus. If it is contracted, I will recess it. And if it is negative in such a situation in here, I definitely would not work on the superior oblique of the contralateral eye, but I would weaken the inferior rectus somehow. So again, this is a summary of his findings, some overaction of the right inferior rectus, underaction of the left superior oblique, and the deviation that is most in down and right gaze, which definitely goes with his symptoms. Again, a healthy 71-year-old gentleman that needed help. I asked him to come back for remeasurement just to make sure that everything is fine. I did advise him to use a tape over his right eye, the eye where most of the hypertrophy was showing, and come back a few months later for remeasurement, which he did, and his measurements were actually exactly the same, maybe one diopter different here or there. And he hated the tape, and he said, why should I live the rest of my life this way? And I agreed with him. So I'm going to stop here a little bit and ask my colleagues on the panel to see if so far they have any comments about the diagnosis, or most importantly, what would be their approach for surgery on a patient like this. Dr. Yam, you can carry it from here, or anybody from the panelists can volunteer and say something, if you like.
May I?
Please.
Mohammed, I think you presented the case very well, and if it's after 3-4 months still stable, I can imagine that this patient would like to have surgery. And then I would go straight forward, as you mentioned, do the forced duction test, which you best can do under general anesthesia, and then see whether it's a contracture of the ipsilateral superior rectus and recess that, or go for the inferior rectus on the contralateral side. You didn't see any upshoots in adduction of the left eye, what I can see from your...
Correct.
Yes.
Correct.
Yeah.
Correct. Okay. Anybody else? Hala, Dr. Saeed, Hatem? Okay, so let's go ahead for the sake of time and proceed. So as Jan just said, you know, we would consider a left superior rectus recession if the post-action test is positive. I listed in here a left superior oblique tuck, which is a little bit weak, but you know, this is a tuck procedure is fun to do, fun to show the residents and fellows, but you know, you always run into the possibility of overcorrection and creating a Brown syndrome. And even though I live with it, I don't usually rush for that. So with that in mind, I said, let's go with forced action test. And then if it is negative, we will weaken the inferior rectus muscle somehow, either by recessing it, putting a posterior fixation suture on the inferior rectus muscle without recession, or doing both a small recession as well as a posterior fixation suture. So the forced action test showed no to minimal restriction of the left superior rectus muscle, which according to the clinical presentation and the non-cardinal position of gaze, I was not surprised with, and proceeded with a small right inferior rectus muscle recession of 3 to 4.5 millimeters and applied a posterior fixation suture 9 millimeters behind the original insertion. I use non-absorbable suture, and I take my suture onto the sclera, not through the pulleys. Immediately post-op, he presented elated with his alignment. He was ortho in primary position, and his hypertrophy now was gone. And his good alignment, again, orthophoria in primary and in all other gazes except for a small XT, persisted 3 months, 6 months, 12 months, and 18 months later. So he is happy. I was happy, otherwise I wouldn't have presented this case. These are his measurements post-operatively, 12 and 18 months later. Very small exophoria, very well controlled. Excellent stereopsis of 42nd of arc. He is, Wilczewski head test is still positive, obviously. And he had an intermittent small angle of right head tilt that he would have every now and then. So in summary, this is my approach. Again, positive forced action test to recess the ipsilateral inferior rectus. Negative, weaken the contralateral inferior rectus. My go-to procedure lately, especially when the deviation in prime position is very small, is either not to recess the inferior rectus, but to definitely consider a posterior fixation. And in some cases like this one in here, I elected to recess the inferior rectus a little bit, essentially to overcome any postoperative scarring and you know, consecutive hypertropia, and deal mostly with a posterior fixation suture that had helped me in a lot of these cases with concomitant strabismus. So that's my presentation. I'll be happy to answer any questions if I can.
Thank you very much, Dr. Jaffer, for the excellent presentation and highlighting to us the importance of the forced action test to differentiate how we approach. Dr. DeFabra had questions.
Yes, Mohammed, thank you for pointing out the possibility of using a posterior myopexia. Did you really do a myopexia, or did you use, how do you call it, a pulleyfaden? And what material did you use for it?
I usually, I don't remember exactly what I used for this specific patient, but I'm using either a 5.0 or a 6.0 Merceline on those patients. And I took my suture into the sclera.
Okay, yes.
Into the sclera, not a pulley
Yeah. No, it's thank you for pointing that out, because I would never have thought about that opportunities. You see, I'm old and I'm still learning. Thank you.
Dr. Hilary.
Yes, I just wanted to say that this is an excellent result, and that my traumatic foot nerve palsies are the worst patients, they're the ones that that are not as happy as I would like them to be, and it's a perfect choice of procedure. I might not have done so much recession of the inferior rectus for fear of developing hypertrophy and primary position, but it's a great result.
In my hands, anything less than 3 millimeter recession doesn't really touch the primary position much. And again, I was more concerned about inducing a hypertropia.
Yes.
Didn't do it. Thank you. Any other questions, maybe from the attendees?
Yes, we have. First, I have a question for myself, if you allow me. You chose to do a fathom procedure here, a posterior fixation suture, and that gives away the opportunity to do an adjustable. People who are proponents of adjustable would think like this is a case you may want to do adjustable recession of the inferior rectus, and adding an adjustable suture may be more useful than having a posterior fixation. What do you think about this? Would you prefer having an adjustable? Do you think the posterior fixation is essential to have in this case?
I think so, yes. I do think so. The deviation in primary position was very small, Amr, really very small. And I really could not touch him in down gaze unless I would do a significant recession of the inferior rectus, which will make him diplopic in primary position, which again, he was not. So I would not, you know where Washington is and where Baltimore is, it's at the two poles.
Oh,
not north and south, but poles. So we go from our good friend, my good friend, David
Guyton,
thank you. David Guyton, who essentially adjusts everybody. To myself, who essentially do not do adjustable sutures. So that's you know, again, this is my bias. But even if I would do adjustable sutures, I would not have used it in this specific patient because again, you really want to minimize the primary position effect and maximize the down gaze effect. And posterior fixation sutures are perfect for that.
Yeah, that is the issue because I know some people are big proponents of adjustable. Dr. Hatim, please, you have a comment?
Yes. There was no inferior oblique overaction at all in this eye? No,
not at all. But again, I saw him 3 years after he presented with his spread of commentants, essentially giving us the presentation that we had in here. I mentioned that I remeasured him 2 to 3 months afterwards, which I've learned early in my career not to operate on any patient unless I measure twice. Because you know, you can be fooled by that one exam at some point. So no inferior oblique overaction. If there was inferior oblique overaction in patients with superior oblique palsy and inferior oblique overaction, this is my go-to procedure.
Yeah, I just wanted to say that it's unusual actually in a traumatic fourth nerve or in an acquired palsy to get a marked inferior oblique overaction. You usually have a superior oblique underaction, and that's actually the hallmark for me of it's one of the things that differentiate between whether this is an acquired or a congenital palsy. The inferior oblique overaction is more with the congenital, and the underaction of the superior oblique is more with the acquired.
Okay, back to the audience questions. Probably people have different ways of doing things, and as you said, like in Baltimore, they would definitely say adjustable for this. I have several questions from the audience from different parts of the world suggesting why not do a Scott procedure or a recession resection would have worked the same. Do you have experience with Scott procedure in this?
Not in a patient like this. I've used the Scott procedure on the inferior rectus muscles, but in a very different situation, like, you know, if you had a severed inferior rectus muscle or something like that. But, you know, he had healthy muscles that unfortunately became imbalanced. And I thought that the, you know, posterior fixation suture again would weaken the inferior rectus muscle in its field of action. I mean, this is where the main weakening is. And it has worked in this patient, but it has worked on many, many other similar situations for me.
So the Scott, how different would it be if you do the Scott procedure? I mean, what would be, what the expected result? Because I have a lot of the audience here suggesting that we would recommend that they would do Scott for this one. How do you think the result would be?
I have no experience. I have no experience in that.
Okay. And again, we have a lot of people suggesting doing a tucking of the superior oblique. Why didn't you choose doing a tucking for this one?
Because his quote unquote interaction of the superior oblique was minimal at this stage, again, 3 years later. And so if I want to tuck that superior oblique, again, without adjustable sutures, I would be on the very conservative side, and I would probably tuck a maximum of 6 or 8 millimeters. Anything more than this in a patient like that, you know, older patients which are acquired superior oblique palsy compared to the congenital, they have a very small fusion potential vertically. And you can really flip them, even in primary position. I'm not that much concerned about Brown syndrome, but I would be concerned about doing too little and not affecting him, or doing a little bit too much and causing the hypotropia to become, sorry, the left hypertropia to become a left hypotropia. So that's why I usually try to stay away from the superior oblique unless I have to. And I do it, but you know, if there are other alternatives, and this patient I think was a good example.
So I have a question from the audience. I have a question to the panelists from myself actually. How often do you do superior oblique tucking as a first procedure in a superior oblique palsy? I mean, for myself, I almost never do that.
It's acquired very, very rarely. In acquired very rarely. In congenital, especially with a very significant tilt, I do it. But in acquired, I try to stay away from it, because again, I cannot titrate very well. And as I said earlier, I'm not a big fan of adjustable sutures. It prolongs my day unnecessarily.
Yeah. Dr. Hatem, any experience with a superior oblique tucking as a first step for superior obliques?
No, I don't like to start with it at all. I'm afraid of having an acquired Brown syndrome.
Okay.
I do it very, very unusual.
Okay. Dr. DeFaber, Dr. Hala, any opponents?
Tucking of the superior oblique, I do it. I think 1 out of 20 cases I would do a tuck. So I'm more very often I do an inferior oblique overaction recession. So that's the ipsilateral antagonist, weakening of that, with an additional inferior rectus recession on the contralateral side. But this was a special case. This was more a case that, especially in primary position, was almost ortho, and there was not really an upshoot in adduction of the left eye.
Dr. Jafar, we have a last question, which is taking us back to Baltimore. We'll keep going there. It says, would you include inverted Brown pattern caused by tightness of the right inferior oblique described by David Guyton in the differential diagnosis of this?
I'm sorry, I didn't get the first part of your question.
Would you include the inverted Brown pattern caused by tightness of the right inferior oblique described by David Guyton in the differential diagnosis of your case?
I think about it. Again, we're very close to each other city-wise and friendship and collegiality. And David has very good examples and presentations about that. I didn't feel this is the case on this patient. I really did not.
Okay, it was not on the list of differential diagnosis. So thank you everyone for this interesting discussion about superior oblique, and we move on to the last talk for tonight. Dr. Hatem Saeed is going to have a talk about post-operative diplopia, post-cataract surgery diplopia.
not working in my eye.
Since we have a minute while we share the
Yes,
presentation.
Please, yes, please.
Dr. Jafar, we have one last question that we really wanted to ask since you have a minute here. How far posteriorly do you do the posterior fixation suture? 9 millimeters. Do you change that number or is it a fixed number?
I try to go as posteriorly as possible while staying safe. So then usually I would like to do a minimum of 8 millimeters. So 8 to 10 is where I go for.
But if you were able to go more posterior, you would go more posterior.
I would go to 10. Yeah, I would go to 10. I don't think in a normal eye, it's not a myopic eye. I really don't think we need to go further than that. Anything less than 8 does not give you the desired effect, which is essentially not affecting the primary position and having the main effect in the direction of gaze of that muscle. For the lateral, you probably have to go even farther back.
Okay. And if you happen to have an overcorrection in this case, what would you have done next?
Refer the patient to Baltimore.
Okay.
I really have not. The only time that I regretted it would be an undercorrection, but not an overcorrection. And so I don't have any overcorrections with those patients. Undercorrection may be the case, and then if this is the case, then you may have to work on the ipsilateral superior oblique or consider some prisms or something like that. But I don't recall having any overcorrection in these patients. Obviously, this patient has responded the best. Otherwise, I wouldn't have presented it. But I can't remember overcorrections with a posterior fixation.
Yeah, that's the good thing about the FADN, that overcorrections are not that common. Dr. Hatem, we're ready. If your presentation is ready, please go ahead.
Yes.
We can see your screen now.
Yes, thank you. First of all, I want to express my pleasure and honor to be with you tonight among this group of distinguished strabismologists. My talk tonight will be about a topic that I see more like a puzzle that has to be solved. It's about the post-cataract surgery strabismus dilemma and the diagnosis of this topic, of this issue. As we all know, persistent binocular diplopia after cataract surgery can be caused by either pre-existing disorder masked by the cataract or prolonged occlusion by the cataract, or the topic that I'm going to discuss today in details, which is anesthetic myotoxicity or the optical aberrations associated with aphakia and pseudophakia. The proper term of this disease is strabismus associated with local anesthetic injection. The previously used term, the local anesthesia myotoxicity, is not that correct, as we are going to see shortly. It's becoming a recognized cause of strabismus after ocular surgery, especially the cataract surgery. There are 3 main clinical patterns that depend on the extent of the damage and the cellular response. If the fibrosis involves a large portion of the muscle, a restrictive pattern will occur, with the deviation being greatest opposite to the field of action of the involved muscle, and the force reduction test will be positive, of course. While if fibrosis involves a small segment, an overaction pattern will occur, with the deviation being greatest in the field of action of the involved muscle. And if muscle degeneration is extensive and the fibrosis is minimal, a paretic pattern will occur. Some theorists suggested that left eye involvement might point to a faulty technique, with the right-handed surgeon being more awkward during injection of the left eye. The susceptibility of muscular injury by anesthesia depends on several factors like the volume and concentration of the drug, the site of injection, the age of the patient. We know for sure that older individuals have tendency for contracture, and an unspecified individual susceptibility. The contracture of extraocular muscle following local anesthesia was thought to be limited to the inferior rectus muscle by virtue of its location and by the huge amount of deviation. The precise pathogenesis is not yet clearly known. It might be due to increased tissue pressure or mere myotoxicity. Can the injected muscle overact? A lot of theories say yes, it can overact due to a change of the length tendon curve, which increases the muscle strength. So when we speak about vertical strabismus post-cataract surgery, we speak about inferior rectus anomaly, whether it's an overaction with the hypotropia being greater in down gaze or tightness with the hypotropia being greatest in up gaze. It's not clear if a preceding paretic phase has been present or not, because we see it so long after the cataract surgery. Usually those patients respond very well to large inferior rectus secession. You might need to weaken an antagonist of a paretic muscle. Adjustable sutures are useful, and they are usually grateful. However, this beautiful scenario is not faced all the time. In this case, he had a cataract extraction and lens implantation in his right eye, but the problem appeared as soon as the patch was removed. A big right hypo. I observed him sometime, hoping for any paretic element to recover. Deep inside, I thought I knew the diagnosis. Here are the pictures in the primary position. As you can see, he has a right big hypo. And when he switches fixation, he has a big left hypertropia. But please note that he has an unexplained upper lid retraction in the right eye. I don't know why does he have the retraction. As you can see, he has a limitation of elevation across the board, hypotropia in up gaze and down gaze, and hypotropia is greatest here in the up and out position for the right eye. So I said to myself, well, it's a straightforward case, go and fix it with a right inferior rectus secession. And that's what I've done on a hangback suture using an unabsorbable material. And force reduction test was positive at the start and became negative after muscle disinsertion and remained negative until the end of surgery. Astonishingly, post-operatively, nothing has really changed much. I wonder why. Could it be an inferior oblique insult being in the same muscle complex? This was the most likely diagnosis for me. Could it be a superior oblique overaction due to its injection with the drug, with the injection being done in the superior nasal compartment? This was the secondly likely. Remember that we don't see the sites of injection at the time of the cataract surgery. We don't know where the drug was really injected. Could it be a superior rectus palsy, coincidental? Could it be an acquired Mets syndrome? So I had to dig in the literature to see if muscles other than the inferior rectus can be involved during administration of local anesthesia. I searched for the inferior oblique and the superior oblique. The inferior oblique muscle or nerve injury, could it be injured in an infratemporal peribarbar block? I found my dear friends, Dr. Gatter and Dr. Hunter, reported that there are cases of inferior oblique muscle injury from local anesthesia for cataract surgery. They reported 4 patients, 3 of them had inferior oblique contracture from myotoxicity, and 1 of them had inferior oblique paresis from direct injury of the nerve. And they reported that inferior oblique muscle or nerve injury should be suspected when significant thumb distortion and accompanies a vertical deviation. As you can see in this illustration, the nerve innervating the inferior oblique is really vulnerable to trauma during anesthesia because it is present in a relatively exposed part of the inferior orbit. Of course, differentiation between the inferior oblique contracture and paresis is easy by the onset of diplopia, by the deviation of the operated eye, by the thumb distortion. They also reported, Dr. Hunter and Dr. Gatton, that the superior oblique can be injured from local anesthesia. It gives usually the picture of an overaction, an acquired Brown syndrome-like, with a delayed onset of diplopia and the deviated eye being hypotropic and intorted, and the intorsion being greatest in down gaze. So since muscles other than inferior rectus can be involved, then how to proceed? First, we have to locate the injured muscle. The 3-step test wouldn't be of much help to you because it is designed originally to identify an isolated paretic cyclovertical muscle, not a contractured one. What I see very beneficial is looking for ocular torsion, either objectively through thumb distortion or subjectively through double Maddox rod or Lancaster Reading green test. Remember that vertical muscles have less torsional action than the obliques in the primary position. Most cases of inferior rectus contracture have mild torsion and mild torsional diplopia, while a significant thumb distortion or torsional diplopia usually signifies oblique muscle dysfunction. Back to my patient, what have I missed? I have missed for sure looking for thumb distortion. I've missed that the hypotropia was greatest in up gaze, and I've missed that the problem started immediately after the cataract surgery. These findings were consistent with paresis of the right inferior oblique muscle, with the hypotropia being greatest in up gaze, and the immediate onset of the problem nullifies the possibility of inferior rectus contracture. So probably the anesthetic needle may have severed the nerve to the inferior oblique, causing an immediate hypotropia and fundus intorsion that I hadn't looked for. So what ideally should have been done, weakening of the superior oblique, in addition to what I've already done, which is the weakening of the right inferior rectus muscle. Still, there are some questions yet to be answered. What's the explanation of this right upper lid huge retraction? And what is the explanation of the vague results of the force reduction test? I learned the lesson, as Dr. Hala said, from this case. In my second case, a 70-year-old patient who underwent cataract extraction and lens implantation in his right eye. Now he's presenting with left hypertropia, since the right hypotropic eye is the fixing eye. It has a better vision since the left eye still has cataract. Here are the primary position photos. And here are the movement in the 9 cardinal directions. And as you can see, the greatest angle here is down and out for the right eye. So these are consistent with overaction of the right inferior rectus muscle. A screen wouldn't be that helpful. So going for the torsion, remember that with ocular torsion, the patient subjectively feels that the object tilted in a direction opposite to that of the torsion. For example, he will feel the objects intorted when his eye is extorted. So when the patient is asked to straighten these tilted objects, an extorsion on the double modex or the Lancaster screen will result. As this photo showed a right subjective extorsion of about 10 degrees. The Lancaster green plot of this patient, remember he's fixing with the left eye here, the non-problematic eye here. He has a right hypotropia, a V pattern ET, and right extorsion, which is greatest in adduction of the right eye, which is the torsional field of action of the inferior rectus muscle. The V pattern ET is consistent with inferior rectus overaction because adduction is a tertiary action of the inferior rectus muscle. The subjective extorsion greatest in adduction, and the horizontal, vertical, and torsional components of the deviation all implicate the right inferior rectus muscle to be involved. Can we demonstrate subjective extortion by the patient in the absence of Lancaster red and green test in your clinics? You can do it easily with a custom vision sharp projector using a red and green filter in front of the patients. You use always the red filter in front of the eye that is in doubt. Make him see this picture and relate the tilt of both images to each other. As you can see, his right hypotropic eye led to an elevation of the image and intorsion of the image. So when he's asked to straighten this image, he will extort it on the screen. Fundus examination confirmed a +1 anatomic extorsion. The macula was only half disc diameter above the upper edge of the optic nerve head in the indirect ophthalmoscopy view. Don't forget to do brain imaging. To sum up, 4 patterns of post-cataract vertical strabismus can be seen giving the usual size of local anesthesia injection. It can be inferior rectus myotoxicity from infratemporal injection, which is the most common. It can be inferior oblique myotoxicity from infratemporal injection. It can be inferior oblique paresis from infratemporal injection, and it can be superior oblique myotoxicity from superior nasal injection. My preliminary guidelines for diagnosis, of course, definitive guidelines should be based on the result of intraoperative force reduction test. If you are facing a case of hypertropia, look for the torsion. If it is associated with extorsion, you are probably facing a case of inferior rectus myotoxicity, and the most appropriate way to deal with is inferior rectus recession. While if your hypotropic case is associated with intorsion, you are either facing an inferior oblique paresis or superior oblique myotoxicity, and in both situations, the most appropriate way to deal with is superior oblique weakening by either method you choose, Z-splatting, tenotomy, and chicken suture, and posterior tenotomy. If your case is hypertropic, this is usually associated with extorsion given the usual size of injection of anesthesia, and usually this signifies inferior oblique contracture that needs inferior oblique weakening. My take-home message is, don't take things for granted based on previous experiences. Although most cases of vertical strabismus after cataract surgery are due to inferior rectus injury, injury to the inferior oblique muscle or nerve and the superior oblique muscle may be more common than previously suspected. Inferior oblique muscle is susceptible, particularly to injury during administration of local anesthesia to the inferior orbital area, and its injury or its nerve injury should be suspected when a significant fundus torsion accompanies a vertical deviation. Evaluation of torsion is fundamental to each diagnosis. Most of the diplopia after cataract surgery may give you a hint, and intraoperative force reduction test is essential. Thank you.
Very good.
Thank you very much, Dr. Said, for the very excellent overview of the strabismus after the post-cataract situation. May I ask the panel, do you have any experience on all these conditions? Because nowadays it seems that post-cataract strabismus is, to me, it's not very, very common. How about the other colleagues? Do you have, yes?
Yes, I remember one of my first papers with Günther van Noorden was an inferior rectus palsy after a retrobulbar injection. This was in the beginning of my career. Nowadays we use topical anesthesia and or Septinon's blunt local injection, so with a blunt needle. In between the intermuscular area, either nasally or temporally. So these cases we don't see anymore.
Dr. Hatem Saeed, thank you very much. You definitely covered almost all causes of myotoxicity. While listening to your talk, I took the privilege, or I sneaked into my files. I don't remember how old that case is, because as you have said and Jan has said, they are becoming very unusual. Oh shoot, I can't. Okay. The point that I want to make is that I had a case many years ago with injection in the superior rectus muscle. So if you would give me a quick second while others are asking questions, I can show you that. And I think if I'm not mistaken, again, this has been many years ago. This has, I got my slide from a presentation or a publication of our good friend, David Guyton. So you said he had present. Yes, go ahead. Do
you have time? Can I make a comment?
Yes, of course.
Okay, it's just that I was I have an explanation for the upper lid retraction, which is, this is most probably fixation duress, because the eye is hypotropic and one of the elevators is not working. So the superior rectus is working extra hard to try to elevate that eye, and as it does that, that also will result in the levator muscle causing this upper lid retraction.
But
so
it was present also when the other eye was fixing. While this diseased eye is hypotropic, it was present also.
I have my slides, if you don't mind. Can I present them really quick? Again, this is, I believe, from David Guyton. This is an injection that was done from an inferotemporal approach, and you can see the long needle that has gone from inferiorly all the way up. This was shown on a CT scan, which shows us the how far the needle can go. And in an artist rendition, we can see, how usually the inferior rectus would be affected, or the inferior oblique, but in this specific case, it went all the way up to the superior rectus muscle and caused an initial initial palsy and secondary contraction of the superior rectus muscle. That specific patient did very well recessing the superior rectus muscle. Force-action test was positive, and so on. So very rarely it does happen. Actually, this is my only case, and I'm 99% sure this was a David Guyton presentation.
And I think this was Hilda Capo, Mohammed.
Maybe with David?
With
possibly.
David, yes. Yeah.
Yeah, possibly. Again, that article showed that it's usually the...
It's Hilda Capo.
Hilda, yeah, you are good. Okay, Kushner Capo. Okay, I wasn't fast enough to review my slides. Hatem, thank you again. That's really very good.
Thank you very much.
Yes, thank you very much. Maybe any question from the audience on this?
We have We have a comment here about the effect of bupivacaine injection into an extraocular muscle and the pathology that ensues, that it causes acute necrosis and then the changes. So Dr. Hatem, since you studied this matter, how would you describe the changes, the stages that we expect to occur? I mean, if you have like a clear injection into the inferior rectus, what do you expect to see in the first days and then the following weeks? What do you expect?
Actually, we don't see it in the first days. Actually, it's referred to you by the cataract surgeon, who is very upset with the result. He did a very good job, and the patient is extremely crying. As I said before, you can never exclude a paretic component to be present in the early days, but actually you see it many, many weeks after the surgery, maybe a month or so. So we can never know exactly what happened during this time. But of course, an paretic component can never be excluded.
Okay, any other comments from the panelists? I think that's all we have for the audience. Any other comments on the case? Well, thank you, everyone. I think we've come to the end of our webinar tonight. I would like to thank all the panelists for their time. I would like to thank the attendees for staying with us in this webinar. I hope everyone found it very useful. And of course, I would like to thank Dr. Yam for being my co-moderator tonight, and he's staying up late. It's almost 3:30 a.m. in Hong Kong. We really thank him for staying that much. We hope everyone enjoyed the webinar. It will be available on the websites if anyone wants to see a recorded version of it. And we look forward to seeing everyone in the future webinars. Thank you, and enjoy the rest of your day.
Thank you very much.
Thank you so much, everybody. Thank you.
Bye.
Bye-bye.
Bye-bye.